Hello, my name is Shannon Langmead, and on behalf of CEC Oncology, I'd like to welcome you and thank you for joining us for today's educational activity titled Rare, Complex, and Under-Recognized, Supporting the Oncology Nurses in the Care of Patients with NF1. This program was supported by an independent educational grant from SpringWorks Therapeutics, and we thank them for their support. Today's activity is brought to you by Creative Educational Concepts, LLC, an award-winning, jointly accredited provider of continuing education for clinicians worldwide. I won't read through this slide, but we'll just mention that these are the credit types that you can receive for this education. We'll also mention that today's activity will include discussion of products that are not currently labeled for use by the FDA. Again, my name is Shannon Langmead. I'm an adult nurse practitioner and the clinic coordinator for the Johns Hopkins Comprehensive Neurofibromatosis Center in Baltimore, Maryland. And I don't have any disclosures. And so we'll just get started with going on to our learning objectives. So today we are hoping to integrate the NF1 diagnostic criteria and oncology monitoring guidelines to support NF1 plexiform neurofibromas, and we will also discuss treatment-making decision and how we discuss that with patients. We'll incorporate MEK inhibitors into the management of NF1-associated plexiforms in both adult and pediatric patients by supporting evidence-based monitoring, safety management, and clinician-led decision-making. And we will discuss evidence-based care plans for patients with NF1 that reflect the clinical standards and support individualized longitudinal management for patients. I'd like to take a minute now to introduce Victoria McCluskey, who is a nurse and also a patient with NF1, who is going to provide us with the patient input or patient perspective as we go through this program. And we'll start off now taking a minute to hear from Tori about living with NF1.
I remember when I was a child, right? I think about other children who have this as well, right? It can definitely vary from their experiences depending on, do they have a mild case or do they have more of like a severe case? Right. So we know that learning disabilities can be one of them. So going through the school systems, the public school system sometimes can be challenging. I think there are a lot more resources for kids now than there used to be. However, there's a lot more children in the classrooms, and maybe resources can be, spread very thin at times, especially if we're looking at rural communities. So growing up, needing extra time on tests, needing more help in school. Also, like if you sometimes children do have a lot of those external neurofibromas. So, sometimes kids are just mean. People are mean and they say mean things and they look at you and it can be uncomfortable. And so it can cause a lot of like depression or body image issues as well. Maybe having to be held back or not like feeling like they fit with their peers because they feel different. They look different. Inside, they maybe feel different because they have this diagnosis.
Thank you, Tori, so much for sharing your input with us. I'm going to start now by talking about the diagnostic criteria for NF1. As you can see on your slides, this diagnostic criteria was recently updated, and patients require 2 of 8 of the diagnosis to meet a clinical diagnosis for NF1. We most often are looking at skin manifestations, including cafe au lait spots, freckling in the axillary or groin region, Lisch nodules or choroidal abnormalities of the eye, and then some bone lesions or bone manifestations like sphenoid wing dysplasia, tibia dysplasia, or pseudoarthrosis. There are also tumor manifestations, including cutaneous and internal neurofibromas, as well as optic pathway lesions, and a first-degree relative or pathologic variant of NF1. NF1 does affect the whole body system. And so it is not just tumor that we see, but there are other manifestations that affect the patient as a whole. And you can see all those listed on your slides here for you. When we think about the first clinical criteria that is often recognized in patients, it is cafe au lait macules. Cafe au lait macules are seen in the general population. Many people have one or two of them. But when we're looking at, over three, we start to wonder if this is representative of a genetic syndrome. In the setting of NF1, as I mentioned on the previous slide, patients have greater to or equal to 6 cafe au lait spots, and the size is dependent upon the age of the patient, but these often are present starting at birth or in early infancy, and they can increase in number as the child gets older. The second most common manifestation we think about is cutaneous neurofibromas. These are benign lesions that are located on or just below the skin. They do not have a malignant potential, but they do have a significant impact on quality of life, including the social stigmata that comes along with having these cutaneous lesions, as well as the symptoms that come along with them, such as itching or pain or rubbing on clothing and things like that. Cutaneous neurofibromas typically start in adolescence and increase with age. And current treatment is limited to surgical removal, and that's blade-based surgery or laser types of surgery, or via clinical trials. When patients present and have cutaneous lesions that are bothersome, we often can refer them to our colleagues in surgery to think about removal of some of the kind of most bothersome lesions, but unfortunately, most of the time, all of these lesions cannot be removed. When we think about the diagnostic criteria or the manifestations of NF1, they really are across the lifespan. Some of these start kind of in birth and infancy, as you can see on this pictogram, and then we have other things that kind of develop as people get older and progress. Again, the cafe au lait spots, the bone manifestations, and plexiform or internal neurofibromas are often present at birth or infancy, even if they're not fully recognized at that time. As children get a little bit older, we start to think about optic pathway gliomas, tumors on the optic nerve, or learning difficulties, speech delays, motor delays, things along those lines. Again, in that period of time between childhood and adolescence, we see some of the skin fold freckling, we see the Lisch nodules, we see some of the other bony manifestations like scoliosis, as well as the beginnings of the cutaneous stigmata of NF1, the neurofibromas, cutaneous, subcutaneous ones. There's also a risk for brainstem glioma at this time. And as we go into adulthood, the risk of MPNST, malignant peripheral nerve sheath tumor, breast cancer, and some other gliomas are also present. But what's really important to see is that this is truly a diagnosis that goes across the lifespan. This isn't something that you can only have to worry about in a certain period of the lifespan. It really is lifelong. In the setting of NF1, there can be, like I mentioned, clinical diagnosis, and we are more and more using genetic testing also. And so genetic testing can be germline, which is blood on blood or saliva, or there can be additional testing that's done on tissue. Folks with NF1 should be followed by an NF specialist, and that should be a yearly, at least, neurologic exam that is measuring kind of different things that you can see here, as well as eye exams, evaluation of bone, and there's often times where we think about neurocognitive evaluations at certain life points. We're going to start with a case that we're going to use kind of throughout this talk, and this is about Mia. Mia is 6 and has a diagnosis of NF1 that she received in infancy. She is seen for routine care. And at intake, her mom mentions that she's been rubbing her left lower back and skipping activities that she used to enjoy. So mom's a little bit concerned about that. On exam, the nurse palpates a new soft, tender fullness along the left paraspinal area and notes that there's some asymmetry in her posture, which she didn't notice on prior visits. The oncology nurse's role in Mia's case is to recognize the hallmark NF features and track them over time, to take a focused symptom history, asking about when she experiences pain, if she is waking up from sleep with pain, if there's weakness, if there's any other neurologic changes, to document those changes and compare with prior records, and then to communicate the findings with the NF provider that's going to be seeing Mia. Also, communicating with Mia and her family the next steps in terms of evaluations. We're now going to take a minute to hear from Tori, who's going to talk to us about the importance of interdisciplinary care for patients with NF1.
So as nurses, again, we play a very important role on this interdisciplinary team. Not only are we coordinating care, doing a very great assessment, we're also going to be communicating to providers, and we're going to be a great big advocate for our patients. So if there's something going on, we need to use our advocacy skills and talk to the providers and be like, hey, like they're really struggling with this. Pain is a big thing. They're saying that their kid is laying in bed and they're not doing things they used to because the pain's bad. They feel like lonely, and then they don't fit in with their peers. If it's an adult, even saying the same things like, hey, like, I know that their pain, they say, is kind of being adequately managed by pain medicine, but they said they're just really concerned about addiction. They don't want to take pain medicine for the rest of their lives. They really want to talk to you about other options because, again, it's affecting their quality of life. They're not being able to do those things that they find joy in, right? And so we want to make sure that we're using our advocacy skills, speaking from that medical knowledge we have, but using that patient's point of view, and really putting ourselves in their shoes and seeing what we can do to better take care of our patients, their caregivers, and letting the medical team know what's going on.
When we think about multidisciplinary care for patients with NF1, we think about the patient kind of being in the center and all of the different experts that we rely on to help provide the most holistic care for folks with NF1. And you can see in your slides the number of specialists that are often involved in the care of patients with NF1. There's typically there's typically an NF expert that's the primary provider or the quarterback, and then we add in other specialists as we need them, so that the patients get a holistic approach to care. One of the most important people in the role or in the care of patients with NF1 is the nurse. The nurse is often the first clinical point of contact for the patients and family. When we're thinking about medication management, they are often the ones that are providing education about medications and letting the patient and family know about the expected side effects and the timeline and who to contact if they're noticing side effects. Nurses are often one of the most trusted professions, so they tend to be the folks that patients and families are most comfortable communicating with. The oncology nurse during treatment is the person that's providing frequent kind of communication to check on how the drug is being tolerated, to make sure that they're doing all of the follow-up evaluations that they need to. They are monitoring toxicity, and they're providing emotional support for patients and families. When we think about considering a treatment for patients with NF1, one thing that is important to consider is the cognitive implications of NF1. There is typically some degree of cognitive difficulty, not in everyone, but in most folks with NF1, and that can be recognized in some higher level thinking. There can also be some learning disabilities or some inattention or inattention with hyperactivity. And if the NF is seen across multiple generations, then the importance of providing education that is to the patient's level is very important. And we need to make sure that we are speaking and providing education and follow-up to a way that both patients and their family are able to understand and follow. NF1 is a tumor predisposition syndrome. And while most of this is a lifelong syndrome of benign tumors, there is an overall increased risk of malignancy that is a lifetime risk of about 2 to 10%. And there are several malignancies that we can see in the setting of NF1, which are listed in your slideshow. But the one we will focus on today a little bit more is the MPNST, or the ones associated with plexiforms. There are also some CNS and other tumors that we can see associated with NF1. Plexiform neurofibromas are histologically benign. There is a risk of malignant transformation that is about 8 to 13% across the lifespan. These tumors, while typically benign, are very complex and can often act aggressively just in how they affect patients in terms of disfigurement or neurologic function. Previously, there were not good treatment options for plexiform neurofibromas, and we only had surgical options, which is, as you can see in the photographs on your slide, there is not a good surgical option for these kind of diffuse large tumors without a significant morbidity. And so there was a need for a systemic therapy to help these patients. Again, plexiform neurofibromas are typically benign tumors, but occur in about 40 to 60% of patients with NF1. And they can grow both along and kind of within nerve. They tend to be large, they tend to be infiltrative, and they can cause a lot of symptoms, including pain and neurologic dysfunction. And depending on the location of these lesions, they can even be life-threatening, even if they're not malignant, because of how they can grow along the neck and affect airway and things. And we've already mentioned this a little bit before, but these tumors can cause pain, they can cause impairment in function and disfigurement, and rarely life-threatening complications due to the compressive nature of the tumors or their location. Again, the malignancy risk for these lesions is rare, but is present. The primary screening for plexiform neurofibroma is based on history and physical exam. MRI is ordered if there are symptoms that are concerning, or if there are exam findings that are concerning or suggestive of plexiform neurofibroma. There is not screening or imaging in the absence of clinical findings that is typically recommended, as many plexiforms will not cause symptoms. They tend to grow with the patient, and a lot of times can not cause symptoms. However, if they're causing symptoms, if we're worried about their presence, then we do order imaging to evaluate them. And oftentimes there is imaging that is done to follow up on the lesions and make sure that there's nothing changing or concerning. When children typically reach about 18 years of age, they're getting ready to transition from pediatrics to adults. That's the time when we think about a screening whole body MRI to evaluate for the presence of plexiform if they haven't already received imaging based on a clinical suspicion. When we think about plexiform neurofibromas, the things that are most concerning are a new onset of pain, meaning the patients have had this plexiform that we've known about, but they haven't had any pain related to it, or they've had minor pain and now they have severe pain. But a change in pain or a new onset of pain is concerning. If there is a new neurologic deficit, a new change in sensation, a new change in strength, a change in bowel or bladder, that is concerning. If there is a change in how the tumor appears, if it was previously soft and now is hard, or if there is rapid growth of the tumor. These tumors are slow growing. They tend to, like I said, grow with children. They don't tend to be a rapid growth or a rapid change. So if we're seeing that, that is concerning. And any of these concerning findings should be reported to their provider so that additional evaluations can be done. Some of the clinical concerns regarding plexiforms, or if there, again, is pain or a neurologic deficit, but also if there is change in function. So increased difficulty swallowing, increased difficulty breathing, you're noticing a progression of scoliosis or a progression of a bony manifestation, or a previous weakness is becoming more progressive, walking is more difficult. Again, these things are concerning that the plexiform is requiring some type of treatment or intervention. We're going to go back to our case scenario with Mia. As you remember, Mia was having findings suggestive of a new mass and some pain. She underwent MRI, which confirmed a paraspinal plexiform neurofibroma. Over the course of 18 months of following this lesion, the tumor has grown. Mia is now 8 and is reporting intermittent pain and trouble keeping up in her gym class at school. She underwent a surgical review, and given that the plexi encases nerve roots, it is not amenable to a complete surgical resection without significant morbidity, and thus it is judged inoperable. And based on the clinical trial evidence for symptomatic inoperable tumors, a MEK inhibitor is offered to Mia. Again, the oncology nurse's role is to support an evidence-based, informed discussion about the realistic expectations of what a partial volume reduction would feel like over the course of months and the goal for pain improvement. They will provide education about the MEK inhibitor, including how it's administered, food effects, and the importance of adherence. They will help to get baseline monitoring set up, including echocardiogram, ophthalmology, and explaining to the patient and her family why these evaluations are important. And then we'll coordinate with the multidisciplinary team to address any questions or concerns that the family has, and also work to help provide social support and reassure any fears or concerns they have around starting a medication. When we think about starting a treatment for plexiform, as I said before, a lot of times these tumors don't cause any problems, but if they do start to cause problems, if the tumor is growing, if there is a risk for morbidity because of the location of tumor, if there is pain, if there's significant disfigurement, or if there is a functional deficit, or we're concerned about where the tumor is and the growth that it is already exhibited to suggest that if it continues to grow, we foresee there being a big problem. Those are reasons to think about doing or initiating a treatment. Otherwise, if none of those things are happening, the tumor can be monitored. However, if we're seeing any of these problems, we need to think about a therapy. If we decided that a therapy is indicated, then we think about what is available. The first is surgery. When we're thinking about surgery, we are looking at whether or not the tumor can be removed without significant morbidity, how the surgery looks. Is it a single surgery? Is it a stage surgery? What does recovery time look like? If the entire tumor cannot be removed and it can only be debulked, what do additional, when we think about if the age of the child, if this tumor will continue to likely grow, what will additional surgeries look like? We can also think about medical therapies, including a drug therapy or clinical trial options. And are there any contraindications or concerns about starting a drug therapy, and how long we might need to be on a drug therapy? This is where it's really important to have a multidisciplinary team to all discuss together what surgery would look like, what recovery would look like, what we think the attainable benefits are from surgery, and what we think a drug therapy could provide, and what support the family would need for either options. Again, we already talked about this a little bit, but these tumors grow kind of within nerve, and plexiforms often involve multiple nerve fascicles. They are often also highly vascular, which increases the complication risk of surgery, and trying to maintain nerve function while also removing tumor can be quite difficult. And for that reason, complete resection is often not achieved, and most of the time these patients are receiving a more of a debulking, which does not stop the continued growth of tumor, but may help with some of the symptoms. Radiation therapy does not have a known benefit, and also increases the risk of a malignancy, especially in these patients with tumor predisposition. You're radiating a tumor, you're leaving it in the body. And when you're thinking about this in children, the secondary risk of malignancy is quite concerning. So radiation therapy for plexiforms is not something that is offered. Non-surgical management includes continued monitoring, active monitoring and surveillance, keeping an eye on symptoms and deciding when or if there needs to be an intervention, and drug therapies, including the approved MEK inhibitors, which we will talk about shortly, as well as additional clinical trials for other drug therapies. Several years ago, we had the very exciting development of drugs that were finally approved for use in NF1-associated plexiform neurofibromas. And now we have 2 FDA-approved therapies that are approved for both adult and pediatric patients, selumetinib and mirdametinib, which are both MEK inhibitors. And you can see in the pictogram here, the development of tumor in NF1 comes because of a disruption in the RAS signaling pathway, and MEK is one of the targets that were identified, and that is where selumetinib and mirdametinib work to help to prevent continued growth of tumor. You have all of the clinical trial results and data in your slideshow, and so I'm not going to spend a lot of time going over that. But the 2 biggest trials that we think about are the SPRINT trial, which looks at selumetinib in children, and the RENEW trial, which looks at mirdametinib in both pediatric and adult patients. Both of them are looking for partial response of greater than or equal to 20% by volume to suggest to be the primary endpoint, as well as additional secondary endpoints, and also the durability of the response. And then again, you can see the results here. Both showed confirmed partial response with durability. The COMET trial was the selumetinib trial in adults. And so we again are looking at the primary endpoints, which again, both selumetinib and mirdametinib showed a partial response with durability. And in the adult side, they also both looked at pain, which both showed a meaningful response to pain as an improvement from baseline with the use of the MEK inhibitor. While the results kind of vary across the clinical trials, there's several differences, including the patient characteristics, the cohort styles, the limitations, but the data shows that both of these are considered to be equivalent in efficacy and toxicity. Which MEK inhibitor is used is typically based on insurance coverage, provider experience, and that and kind of the toxicities that patients have experienced or are experiencing when they're started on drug. One of the biggest things to look at is selumetinib is continuous dosing. Mirdametinib is dosed at 3 weeks on, 1 week off. There is no head-to-head comparison. They haven't been studied against each other. And there's also no data on switching from MEK inhibitor to MEK inhibitor, though if a patient is not tolerating one MEK inhibitor well, then clinically we do consider switching between the 2 to see if we can get less toxicity and patients can tolerate it better so that they can stay on drug. Sometimes patients feel better with the continuous dosing. They don't have to worry about forgetting to restart drug. Some patients really appreciate having the 1 week off per month of not being on drug. And so talking to your patients about kind of how they feel they would do best could play a little bit into kind of which drug is prescribed by the provider. In general, MEK inhibitors are a novel treatment for NF1 associated tumors. They are overall tolerated well, but there can be both mild and severe side effects. They do tend to be age-related. There seems to be different side effects that we see more in the adult population than the pediatric patients. One of the most important things to consider is that treatment can only be effective if patients remain on drug. Side effects happen 1 to 2 weeks after starting drug. The benefit of drug oftentimes isn't fully recognized until patients are on drug for 8 to 12 months. So it is quite possible that if we can't get patients to stay on drug, we might not ever see the full benefit that they could attain from it. To maximize the drug therapy and the tolerance, the appropriate management of toxicities is critical. And again, that comes into the role of the oncology nurse, as they are often the ones who are first communication with patients, talking about the toxicity, reinforcing what the expectations are in terms of, we know these side effects are going to be here. How can we best help you manage them so that we can stay on drug and try to get you benefit? Thinking about toxicities, it is very important to share with patients the most common toxicities. We think about how we can prevent toxicities or manage them as they occur. We think about the effects of drug on quality of life and how we can keep patients on drug for a long time, because as I mentioned, they oftentimes see the side effects early but don't get the full benefit of drug until they're on it for quite a bit longer than that. So understanding the potential benefits, the timeline of the response of tumor to drug, and how to best get patients to meet that. Almost all patients that are on MEK inhibitors experience some degree of toxicity. In children, can be mild rash, some paronychia, some some ophthalmologic manifestations, and some muscle weakness. In adults and adolescents, the rash tends to be a little bit more prevalent. We can also see some GI side effects, as well as some fatigue. You can see in your slides the percentage of patients that experience the different side effects across both drugs in the MEK inhibitor class, selumetinib and mirdametinib, in both pediatrics and adults. The most common is the skin toxicity. This is an acneiform or eczematous rash, as well as paronychia and palmar-plantar erythrodysesthesia, PPE. There can also be some folliculitis. The skin manifestations, the skin toxicities, are the most common cause for MEK inhibitor dose modifications. And this can happen in 25 to 40% of patients in the pediatric trial required a dose modification for the skin toxicities. Because we know the skin toxicities happen, we oftentimes give patients kind of a stepwise approach for how we are going to manage the toxicities, oftentimes giving them a toolbox. This is how we start. We're going to start with moisturizer. We're going to avoid excess sunlight. We're going to use gentle soaps, and then we give them either prescriptions or when to notify us so that we can stepwise increase kind of the treatment to try to prevent the rash from being the reason why they have to come off drug or why we have to dose reduce. Sometimes in adult patients who are very concerned about the acneiform rash, we can often even start them lower down with an antibiotic or topical antibiotics or oral antibiotics as a prophylaxis so that they don't have to wait for the rash to occur and then try to treat it. We try to get on top of it kind of before it happens. So we have typically start with topicals, but have a very low threshold for ordering oral medications to try to manage the rash. As you can see in the photos in your slides, they can be quite severe. And for adult patients who, this can be a little bit more disconcerting, as well as, school-age children who already feel like there's a social stigmata to their syndrome, now have this skin rash to deal with on top of it. You will be able to see in your slide deck kind of the escalating treatments that we use, as well as having a very low threshold to ask our dermatology colleagues to help in managing these symptoms, and or holding drug or reducing dose if we need to. PPE, which you can see in your slide deck also, can be quite severe, cause a significant amount of pain for children. It can make things like participating in sports or activities more difficult when they have blisters on their feet or hands, as well as professionals trying to work with these can be quite difficult. So they are something that we keep an eye on, and we are quick to treat when we see it happening. Again, we give patients kind of a toolbox of how to address treating the symptoms of PPE and how to escalate the treatment so that we can try to get a handle on things before they require holding drug or dose reducing. Paronychia, we talk to patients about this side effect and again give them instructions on how to manage should it occur so that they can, yes, send us an update, let us know what's happening, but they already have what's needed at home to start kind of treating, and they already have instructions on how to manage this. So we know that the skin side effects happen. We prepare patients for this. We anticipate what they're going to experience, and we give them kind of a toolbox to address symptoms as they arise. And then again, in your slide deck is the eczema-like rash and how we manage that, again, with escalating treatments so that patients are prepared to manage this and we can get on top of it before it becomes something that requires drug hold or dose reduction. Additionally, we can see dry skin, we can see flaky scalp. We use medicated shampoos if we need to, and again, dose escalating or treatment escalation to a antibiotic lotion or ointment if needed. We can see some GI side effects that can be nausea, vomiting. It can be pain or cramping. We can see some diarrhea. There can be some weight loss or weight gain. All of these are things that patients are encouraged to let us know so that we can help them to monitor, manage, use medications if we need to, or use lifestyle modifications, diet modifications if needed. In your slides, you'll see some of the other relevant toxicities, including ophthalmologic toxicities, proteinuria, elevated lab findings, and the frequency at which these things are monitored. Eye exams are at baseline and then every 6 to 12 months for ophthalmologic complications. Echocardiograms are important as well as lab studies. CK is almost always elevated in these folks, but is not something that requires dose modification unless they become symptomatic. So helping people to understand how to prevent becoming symptomatic from elevated CK, such as hydration status, and limiting activities that also cause an elevated CK can be helpful. In your slideshow, you'll also see some of the long-term outcomes that were studied. In the sprint cohort, the selumetinib one, there's a 5-year duration that was evaluated and no new safety concerns were identified during that time period. And in the renew cohort with mirdametinib, again, a 2-year duration was evaluated and we did not see any new or concerning safety findings during that extended evaluation period. There was no lasting vision changes. So in the ophthalmologic complications, there was no lasting vision changes found when looking at the long-term safety data, and no long-term hematologic complications noted. We will go back to our case study with Mia. About 6 weeks after starting the MEK inhibitor, Mia developed an acneiform rash and an eczema-like facial rash. and some redness around two of her toenails, suggestive of paronychia. Her mom called the clinic. She was worried and she asked whether or not Mia should stop drug. Again, the nurse is oftentimes the first clinical contact by the patient. So the nurse was able to triage and grade the toxicity for Mia. Started the protocol based on skincare using emollients, topical clindamycin, hydrocortisone, and antiseptic soaks for the paronychia, reinforce the adherence of that benefit may take months to notice, but the side effects are expected and often occur sooner, that these are low grade and we can help to manage them by doing the different treatment interventions, and that these low grade toxicities are not a reason to stop drug. They talk about how we can escalate to dermatologic involvement if we need to, and that we would only dose modify if with escalating treatment, there is not any improvement in the toxicity. The oncology nurse often just provides support, knowing that these toxicities, even though they are low grade, can still impact quality of life and has the risk to impact adherence to drug. So making sure that the family is reassured, making sure they understand that we understand how impactful these side effects can be on quality of life, and that we're working together with them to try to help to manage them so that they can continue treatment. We're going to hear again from Tori about how nurses can best talk to patients about living with NF1.
So talking to children and adults about managing a lifelong condition can be hard, but I think it's something that we don't do in one visit. So again, this is a lifelong condition, so people are going to be seeing the doctor, every couple months, maybe annually. So maybe in that time frame that we have, providing the education and asking people, hey, how are you really doing with this? Like, what concerns do you have? What fears do you have? What questions do you have? Let's address those while we're in the room together. Because yes, we can do it through my chart. We can answer questions through messages, the patient portals. We can answer on the phone, but face to face, you can get better sense, especially with those nonverbals. Breaking it down to their language, and then over time, we go over it and use age-friendly materials, age-friendly language. So again, my kid has it. So sometimes I'll be like, hey, he asks about it. And I'll say like, hey, we have like those coffee spots on our skin, the birthmarks, the cafe spots. I call them coffee spots. And so I go, look, we're twins. We have them. And so, or like, hey, the reason why we get these scans is so we don't have to see if there's any bumps. He doesn't need to know we're checking for a big old tumor or anything like that. He just needs to know, hey, you have to go in there. We just need to make sure that there's no bumps in there. And when he gets older and he's, I can understand more, we can go into those details. So again, use age-friendly materials. Utilize that time when you meet with the patient, whether they're adult or a child, and their choice of caregiver.
Now we're going to talk about the transition from pediatric care to adult care. In the setting of NF1, we've already established that this is care that needs to take place across the lifespan. So as we start to think about this, we're going to go back to our clinical scenario with Mia. Mia is now 16. She's had some improvement with MEK inhibitor treatment such that there is a reduced tumor volume and she has improved symptoms such that her pain is better. Like many people with NF1, she is learning, she has some learning difficulties that can affect self-care and self-management readiness. And so the team recognizes this and starts to think about preparing her for transition to adult-focused care, understanding that it will take a couple of years to ensure that she's ready to make this transition. The oncology nurse's role is to help identify when the patient is ready to start thinking about the transition process, planning for this early, assessing self-management readiness, building a medical summary to coordinate handoff to adult providers, confirm insurance and coverage continuity for MEK inhibitors to avoid treatment gaps, foster Mia's growing autonomy while keeping the family involved, and safeguarding continuity and monitoring across the handoff from pediatric to adult care. One of the things that clinically we notice is that there are a lot more pediatric NF centers than there are adult NF centers. And trying to make sure that patients know where they're going when they're leaving pediatrics, who the correct provider is to see, making sure that handoff is there, that the patients and families feel comfortable with the handoff, that they know how to get in contact with that clinic, that that clinic knows how to get in contact with their pediatric provider so that there is not a disruption in the care that patients are getting, especially when they're on a long-term therapy like a MEK inhibitor. You can see in your slides that there is a little bit of difference in the delivery of pediatric and adult care. In the kind of most important is that the pediatric care is a family-centered model where the adult care is patient-centered. The access to multidisciplinary clinics for adults is a little bit more difficult to find than pediatrics. And there are some other things that you can see that I'm not going to spend too much time on. But it is very important to recognize that this is a lifelong condition that care needs to care needs to continue past pediatrics and into adults. And while some of the things that you can experience as a child are not things that you experience as an adult, there are other things associated with NF1 and that continue to be a concern that need ongoing care and management. There's a slide in here that kind of talks a little bit about understanding when there is, when you can start to recognize the elements that show that a patient is ready to start thinking about the transitioning process. In pediatrics, it is starting to recognize when patients can take control of their own medications and be the ones to talk and share things at appointments. It can be a little bit difficult for parents who have had a child who has been ill or has required a lot of care throughout the lifespan to hand that over and to step back and let their child talk. So the role of the oncology nurse is to try to help foster some of that independence in the safeguard of a pediatric setting before that transition over to adult care happens. Being a primarily adult provider, what we can sometimes see is that there's a lot of pediatric NF clinics that are available. There is less adult clinics available. And sometimes pediatric patients or their families may think that they don't need continued care because there isn't an adult center directly linked or related to their pediatric center. And there can be a little bit of a fracture in care or a loss to follow up until something happens that they then present to the adult side of things. So as the oncology nurse who is working with these patients, helping to identify resources to help make sure that they have a clinic that they know about, have contact information for, and can find easily would be very helpful for them. You can see in your slideshow just some barriers that are present when we think about transitioning from pediatrics to adults. Again, the biggest one being the lack of adult providers. For this reason, sometimes pediatric patients stay with their pediatric providers a little bit longer, but there is a time when it becomes a little bit more difficult to do that, and they do need to transition over to adults. And so helping them to find a provider can be really helpful so they don't get lost in the system. We're going to take a minute now to hear from Tori again about her experience with transitioning from pediatric to adult care.
So as nurses, it's really important that we always continually provide education because we know our pediatric patients are going to become adult patients. So what can we do throughout that time span, whether we start seeing them when they're a baby or 10, 15 years old? I remember I lost track when I was younger. I just didn't get followed up because there seemed to be no issues. There really wasn't an NF specialist where I live. And so it wasn't until I I don't remember how old I was, maybe 28, 29 years old. And I started having a lot of hip issues. And I went and saw an NF specialist, and then they found a tumor there. So again, like letting people know what to look out for, when to contact them. And if they're in an area where there's no specialist, giving them the right tools and saying like, hey, this is what you need to tell somebody.
Thank you so much, Tori, for sharing your insight with us. As you walk away from this educational event, there are some things that we would like you to think about, what we call SMART goals. One of those being the NF referral pathway, identifying ways in which you can help get patients in with specialized NF providers, the importance of multidisciplinary NF coordinated care, and especially the importance of your role as the nurse in that coordination of care, and also the transitioning process and starting to recognize and help to guide patients along that process. Just want to thank you so much for being here today and for taking time to learn about NF and how you can support this patient population in these rare diseases. Any additional support that these patients can have and can feel with their providers is extremely important to them. Going to a provider that they don't have to explain what NF1 is really important. And so you being here and just gaining some knowledge is a very big